Good afternoon. My name's Dr. Fiona Donald, and I'm the President of the Royal College of Anaesthetists. And thank you very much to the organisers for inviting me to speak today about quality improvement, perioperative care, and the role of the Centre for Perioperative Care, which brings together those working in this area. I have no declarations of interest to make about this subject. So, I'm going to briefly outline the current challenges in elective care in the UK, although I'm sure you'll be facing many of the same challenges, and so we'll recognise them. I'll describe the Centre for Perioperative Care and the concept of integrated care pathways. I'll then share some supporting materials that have been produced, talk about the benefits of this approach to perioperative care for patients and systems, and finally, I'll outline what's meant by shared decision-making, which is an important part of the process. Recently, of course, our focus has been on coping with the pandemic and its ongoing impact. However, we know there have been serious consequences of that focus in terms of other aspects of healthcare. And in reality, there were problems before the pandemic, which have now been highlighted by its effect. As we can see here, in the UK, the pandemic has led to a big increase in the number of patients waiting for planned care, although there has been a steady increase from around 2.5 million in 2008 to nearly 6 million now. Numbers of patients waiting more than a year for treatment have shot up recently, and this means that in the UK, the number of people waiting for planned care is likely to rise to around 13 million within the next year. These patients may well be becoming less fit, more frail, and their presenting conditions may be deteriorating whilst they wait. So it's essential that we try and reduce waiting times whilst also helping patients to be in the best possible health before they present for surgery. It's clear that continuing to do what we always do in the way we always do it will not be sufficient to tackle this enormous backlog. If we want to arrive at a different outcome, we must do something different, as Albert Einstein has so eloquently pointed out. We feel that now is a good time to look at our perioperative pathways and see whether there are things we could do differently that would allow us to catch up on the backlog and still maintain the quality and safety of the service. The Centre for Perioperative Care, or cpoc, was launched in May 2019 and is based at the Royal College of Anaesthetists. As it says here, cpoc is dedicated to the promotion, advancement and development of perioperative care and is cross-organisational and multidisciplinary. It also importantly has patient and public representation. We feel that coordinated perioperative care may well be the something different we're looking for in these circumstances. You can see here some of the organisations that make up cpoc and which represent a wide cross-section of interested parties. There are multiple medical royal colleges, as well as faculties and associations that have involvement in the perioperative journey, such as the Association of Anaesthetists and the College of Operating Department Practitioners. cpoc launched its first strategy in October 2020, and this strategy lays out the ways in which cpoc will use integrated care pathways to benefit patients, the health service, and the workforce. So let's look at that in a little bit more detail. The first strategic theme is improving our patients' quality of care. And this will be done by defining best practice based on evidence and with the input of patients and the public, and then disseminating these findings to the healthcare community. We must also enable reliable and consistent implementation of this best practice and benchmarking of the outcomes, which we can do through the many existing quality improvement programs that are in place. The second theme is empowering our patients and their carers. This involves providing patient information and involving patients through shared decision-making, of which more later, and other web-based resources such as our Healthy Living resources. We also support patient-focused campaigns such as the Brain Health Initiative, Fit for Surgery, and the Royal College of Anaesthetists' own Fitter, Better, Sooner campaign, which provides a toolkit for prehabilitation or preparation before surgery. The third theme is supporting our workforce, and we'll strive to improve clinical education and training through ensuring that perioperative care is included in the relevant healthcare curricula. The aim is to educate all staff and to build genuine teamwork where everyone knows what they can do and has a remit to take action. The fourth theme is influencing policy. We want to highlight the role of perioperative care in the national health priorities. In the first year, this has involved bringing the importance of perioperative care to the notice of politicians and healthcare managers through publication and dissemination of the research and guidance that's been produced, and emphasising its role in helping to tackle the backlog, prevent lost operating time, and ensure best outcomes. The fifth theme is harnessing digital technology. The pandemic has forced everyone to use more digital technology in their working lives, and we want to take the good bits of this and harness them for patient benefit, always being mindful that some patients are not able to access digital resources and must not be left behind or disadvantaged. We'd like to see more use of web-based resources, patient apps, texts, messaging, and also we'd like to promote digital record keeping in perioperative pathways, which will enable tracking of the patient journey and, importantly, smooth interprofessional communication. Finally, last but not least, the sixth theme is research and innovation. cpoc aims to become a leader in this for perioperative care. It's already produced evidence reviews highlighting the impact of perioperative care and the gaps where more research is needed, and is committed to sharing all the information that's gathered. Teamwork is an important part of the ethos of the Centre for Perioperative Care. And whilst the previous slide talked about multidisciplinary working, it is important to avoid silo working, which can be part of this if there's protectionism amongst the healthcare professionals. The team should think more of a transdisciplinary approach where collaboration is encouraged and the teams share goals and understand each other's roles, and all team members are empowered to inquire and take on new skills. The document shown here, entitled Developing Professional Identity in Multi-Professional Teams, was published in May 2020 and goes into this way of working in more detail. And you can see that there's a link at the bottom of the slide. I'm now going to talk a little bit about integrated care pathways for perioperative care, which means bringing everything together into one streamlined process that allows the patient journey to be as smooth and effective as possible. And I'll also talk about some of the publications that have been produced by cpoc to support this work. This slide illustrates such an integrated care pathway and shows how cpoc hopes to see things done in the future. Starting at the left of the diagram, we can see that from the moment the patient presents to their general practitioner in primary care, they should be involved in the decision-making themselves, and this should continue throughout their journey. At the start, it is important to begin the process of optimization of patients, for example, correcting anemia or making sure diabetes is well controlled, and also to recognize those patients who may present a higher risk due to conditions such as frailty. The patient then moves to secondary care within the hospital, where decisions around the best alternatives for them are discussed, and this may include the option not to proceed with surgery, and then further risk assessments are done. More optimization follows with education and intervention around areas such as exercise, nutrition, smoking, alcohol, and weight management as appropriate. They then move to the intraoperative phase, where evidence-based methods are used to provide high-quality anesthesia and pain management and a safe recovery in an appropriate environment, whatever that is. Postoperatively, they are helped with rehabilitation, and steps are taken to avoid postoperative complication, which is obviously aided by the thorough preoperative preparation. Finally, they are discharged home and followed up again, usually in primary care. Throughout this pathway, all the teams should be communicating with each other and with the patient to make sure that information is not lost and the optimum pathway is followed. And this is where digital technology can be key. This guidance was produced by several organisations, including cpoc and the Royal College of Anaesthetists, in June last year, and outlines how preoperative assessment and optimisation services, which are an essential part of the integrated care pathway, can be set up, and it includes consideration of the constraints due to COVID. It's intended to be used by primary care, by surgeons, anaesthetists, perioperative teams, and preoperative assessment services. It applies to all patients who are being considered for surgery or on a waiting list for surgery in the non-emergency setting. If it's implemented in full, it should mean that by the time the patient has surgery, they have shared in the decision to proceed to that surgery, they're fully informed of the risks and benefits, they've had any significant comorbidities which could potentially impact on perioperative care and outcomes identified and optimised where possible, and they've started to modify their risk factors, and they will importantly have been entered into a system of active clinical surveillance to ensure that significant changes in their health and fitness whilst they're on the waiting list are made known to the perioperative team and can be acted on. This review, The Impact of Perioperative Care on Healthcare Resources, was published by cpoc in June 2020 and was based on consideration of 27,000 studies into the effectiveness of perioperative care. The key findings were that patients feel better prepared and more empowered when high-quality perioperative care measures are in place. Length of stay can be reduced by an average of 2 days for all surgery types, and there is less use of ICU, fewer complications, and therefore costs can be reduced. All of this relies on the integrated care pathway being followed very closely, so it's absolutely vital that all the members of the team and the patient are supportive of that course of action and that resources are in place to make it possible. One of the first guidelines to be produced by cpoc was this one, which they wrote with the British Geriatric Society on perioperative care for people living with frailty who are undergoing emergency and elective operations. These patients are, as we know, at high risk of complications and represent quite a large proportion of the surgical population. The document is summarised in this infographic, which provides a step-by-step reminder, including such things as referring to the frailty team, updating do not resuscitate decisions, and clarifying lasting power of attorney, as well as important steps such as ensuring consultant involvement at operation and looking out for delirium and deconditioning in the postoperative period, which can be quite common. The underpinning principles during this pathway are iterative shared decision-making, streamlined communication and documentation, comprehensive geriatric assessment, and multi-specialty, multidisciplinary working. Diabetes is another very common comorbidity that can lead to a number of undesired consequences and complications in the perioperative period if it's not managed well. This guideline is the first to look at the whole surgical journey from referral to recovery and is proving extremely useful to those of us working in this field. Again, the infographic summarises the information and the full document can be found at the link shown on this slide. Health outcomes are influenced by a wide variety of factors as shown here. We can't easily change the socio-economic factors or built environment factors of our patients, but through our work in perioperative care, we can influence health behaviours, as we've just discussed, and clinical care. And that can make up around 50% of the contributors to health outcomes. So we can see how important it is. As we can see here, postoperative complications are common, occurring in 15% of operations, although rates will vary from specialty to specialty and are made worse by factors such as frailty and inactivity. However, for smokers, for example, just 4 weeks smoking cessation can reduce complications by 50%, and moderate exercise can do even more for the inactive. So there really is benefit in preparing our patients and working with them to improve things. The UK population has high levels of multimorbidity, with 50% of those aged over 65 being classed as multimorbid. And 27% of UK adults do no exercise at all, so there is definitely room for improvement. These things may well have deteriorated during the pandemic as people have been waiting longer for surgery. So it's important to make use of the waiting time and to turn waiting lists into preparation lists where patients are supported to improve their health and fitness. Having talked a little about the benefits of exercise in reducing the risk of perioperative complications, this slide shows the further long-term benefits that can accrue. 150 minutes of exercise per week, or just 21 minutes per day, can reduce the risk of developing a range of comorbidities and, importantly, can treat or reverse those comorbidities in people who already have them. The risk of developing type 2 diabetes can be reduced by between 30 and 80% by exercising, and those people who already have it can improve the condition. The two documents shown on the right of this slide were produced by the Academy of Medical Royal Colleges and the Royal College of Surgeons of England, respectively, and go into this effect in more detail, giving examples of how health workers can, for instance, help patients increase their exercise levels by role modelling. The interventions listed here are all proven to reduce postoperative complications and to improve cardiovascular fitness, reduce inflammation and the metabolic syndrome, increase empowerment of patients, and also help pain control. None of them are particularly expensive to provide, but they do need planning and coordination in order to be effective. The link at the bottom of this slide is to a podcast by the Centre for Perioperative Care about turning waiting lists into preparation lists, where these sorts of interventions can be undertaken as discussed earlier. Patients who have cancer and who need to undergo surgery are one of the vulnerable groups that we deal with. And this booklet, which was developed by the Macmillan Cancer Support Charity alongside the RCoA and the National Institute for Healthcare Research, provides these patients with information about the things we've been talking about. So prehabilitation or coached exercise, along with advice and support about alcohol use, smoking, nutrition, and psychological preparation. As shown on the right, the leaflet outlines the benefits they can expect to see, including reduced length of stay after surgery, enhanced recovery, improved cardiovascular fitness, and better quality of life. I'm now going to move on to talk about shared decision-making, which I've mentioned a few times already. It's really just a way of saying that patients should be involved in decisions about their care. It's the process whereby patients and clinicians work together to make evidence-based decisions about patient values and preferences. This may be to select a test or intervention, such as going ahead with surgery. Shared decision-making ensures individuals are supported to make decisions which are right for them and fit with their goals. Patients who are effectively involved in making decisions about their care have fewer regrets about their treatment, better reported communication with their healthcare professionals, improved knowledge of their condition and treatment options, better adherence to the selected treatment, and an overall better experience with improved satisfaction. Most healthcare workers would probably say they already do this if they were asked, but they probably don't do it to the extent that's needed. There are resources available on the cpoc website describing what shared decision-making involves in more detail. And two of the models of this type of decision-making are the BRAN model and the 3-talk model. I'm now going to show you a short video which describes the BRAN model in a little bit more detail.
Shared decision-making is a practice that encourages patients to be actively involved in decisions about what care and treatment they receive. This is Peter. Peter's speaking to his GP about the results of a scan he's had as part of a national screening programme.
Hi Peter, your scan shows an abdominal aortic aneurysm, a large swelling in the main blood vessel in the tummy. Going forward, there's a few options for how we might treat this, including an operation.
Is the aneurysm dangerous?
There is a risk that it could start bleeding, and if that happened, it is life-threatening. You could die from it.
Oh, it's all a bit frightening.
It is a lot to take in. I want to reassure you that we'll support you through this. I'd like to refer you to a clinic where you can speak to a surgeon about your treatment options.
Peter's GP explains that it's important for Peter to be involved in making decisions about the treatment and care he will receive. Depending on your specific condition and where you live, different tools and resources are available to help guide you through the decision-making process. Peter's GP recommends the BRAN framework.
Peter, have a look at this BRAN leaflet. BRAN is short for the benefits, risks, and alternatives of treatment, and the option of doing nothing. Thinking about these things ahead of your appointment with the surgeon will help you work together to decide what treatment option is best for you.
Do I have to have an operation?
Not necessarily. An operation is just one of your options. We'll support you to choose the best option for you. Give it some thought and consider what is most important to you.
How are you feeling?
To be honest, I didn't realise I'd have a choice, and I'm worried about making the wrong decision. I'll be given a BRAN leaflet to help. It says at the clinic appointment I should think about the benefits and risks of surgery, the alternative treatment options, and what happens if I do nothing for now.
Why don't we write down some questions to take to your appointment?
Oh, that's a good idea. Otherwise I'd forget what I want to ask.
Have a think about what concerns you and what's most important to you.
But the most important thing's our life together. Seeing our grandkids grow up.
Hi, Peter. It's nice to meet you. I can explain the different treatment options and we can make a decision together that's right for you.
I found my BRAN leaflet helpful, and I've written down some questions I have.
Thanks for bringing some questions. Before we go further, I want to understand what really matters to you.
The most important thing to me is to have as much time as I can with my family and be able to look after myself.
Peter's surgeon helps to compare the benefits and risks of the treatment options and discusses what happens if Peter decides not to have treatment at this point, whilst also considering the questions Peter and his partner put together, Peter's concerns, and what Peter feels is most important to him and for his future. Having discussed and explored all the options available to him, Peter's able to be involved in the decision-making around the care and treatment that he receives, with the full support of his healthcare team, so that he can be confident that it's the right path for him. By using the tools available, like the BRAN framework, it's never been easier for patients like Peter to be involved in making informed decisions to guide the care they receive.
So that's one model of shared decision-making, and another is the 3-talk model, which divides the conversation at the consultation into 3 staged phases. The first is team talk, where emphasis is put on working together to arrive at a decision that suits the patient. They're given support to decide what their goals are and how these might fit with the choices that are available. The second part is option talk, where the alternatives are discussed using risk communication principles. And then finally, there's decision talk, which refers to the task of arriving at a decision that reflects the informed preferences of the patient, guided by the experience and expertise of health professionals. So, in summary, I've provided you with an introductory overview of integrated care pathways for perioperative care and the work of the Centre for Perioperative Care. This approach can improve the quality of patient care and their satisfaction with it. It can improve population health and quality of life, and it can reduce the per capita cost of healthcare by improving value. Importantly, this also improves the experience for the workforce and could lead to a happier and more motivated staff, which again feeds back into an improved experience for patients. When it is well designed and well executed, this model of care really can bring benefit to all. Thank you very much for listening.